Welcome to our chat today, which is on mental health. And I'm Dr. Louise Tallow, and I am speaking today with Dr. Juliet Tate. Juliet is one of our lovely VIV doctors, and has many, many years' experience as a general practitioner with special interest in both women's health and mental health. And so she is very well placed for this discussion. Juliet is also a teacher at the University of Tasmania Medical School. So she does a variety of things that I find very interesting. But why don't we get stuck into our discussion today around the difference? Why don't we start off looking at the difference between mental health and mental illness and what those mean?
Sure. Thanks, Louise. I think it's a really interesting discussion because a lot of people, when they talk to me about symptoms that they're experiencing, they say that that their mental health is bad, or that they're saying they're having mental health. And to me, mental health is actually a good thing. Mental health means that you're feeling fine, and you may have the occasional symptom, maybe a bit of anxiety here or a low mood for a few days, but overall, your mental health is actually pretty good. There is a difference because mental illness is where those symptoms of anxiety or depression are pervasive and unrelenting and cause disability and problems with day-to-day functioning. So that's the difference, is that with mental health, overall, you're doing okay. And we all experience symptoms of anxiety, stress, sadness, fear, and that's within the normal range of human emotion. The problem happens when those experiences become so prevalent that you can't see outside those experiences. And the classical definition is when the symptoms are pervasive for more than 2 weeks at a time, and they're impacting on your day-to-day function. So that's mental illness. So with depression, you're experiencing such a low mood that you're having trouble getting up out of bed, you're having trouble doing your work, you're having trouble maintaining your healthy activities, your exercise, your sleep gets affected. Whereas when you're experiencing symptoms that are part of the normal human condition, you may have a few nights where your sleep is poor, or you may have a few days where you're really struggling to get on top of things, but there's always light, or there's always some sense that this is temporary. And that's normal mental health days. And we all talk about having a couple of mental health days and, taking a day off and going and walking the dog and, walking on the beach or something like that, and that being helpful for your mental health, which is very true. Whereas mental illness, often those kinds of things aren't necessarily providing the uplift that we would like or expect.
So I think that's one of the things, is that to experience the full breadth of being human means you have ups, downs, and you have variety of experience. It's not just all happy, it's not all contentment, and this is normal. And it is important to experience those different variations in mood and feelings. Why is it important not to over-label ourselves with having mental illness?
I think that it can be quite disabling to label human condition or symptoms as a mental illness, for example, anxiety, because it restricts our capacity to heal, because the people around you, if you've been given a diagnosis, the people around you are affected, and although they do try to help you, it can actually restrict your own capacity to heal or to feel better, because it's almost like you're weighed down by this label. And there's also a impetus to try and treat and make change for this diagnosis. Does it, if you've got a diagnosis, then you need medication and you need a psychologist and you might even need a psychiatrist. When that's not necessarily the case. The case may be that you need to empower that person or empower yourself to make changes to your life that are going to improve those symptoms and help you achieve mental health as such. How does
Yeah.
that sound? Does that make sense?
Yeah. Yes. And in fact, we know this from researchers studied this actual fact that it does. If someone is given a label, for example, anxiety disorder, then those around them may become more empathetic to that person's experience, but they also have an expectation that they won't recover. And the person themselves has an increased expectation that they won't recover, that this is something they'll have all their life, and that reduces their agency to do something about it. So there is negative perspective about giving someone a label that is not even that is not appropriate. So what happens around the perimenopause and menopause to our mental health?
Oh,
In
there's
pregnancy.
there's no question that around the perimenopause, women's mental health is affected. A large proportion of women experience symptoms associated with anxiety, such as like the physiological symptoms like palpitations, lightheadedness, a sense of impending doom, that kind of thing. Those symptoms can be quite prominent in the perimenopause. And irritability, excuse me, irritability is a really, really common symptom. And that can be associated with mood changes. So you might find that something that normally you just brush off and it wouldn't be an issue for you suddenly becomes an issue that you can't let go of, and it feels so encompassing. But you part of you also knows that it's not really that big a deal, and it feels almost like you've got no control over how you're experiencing those anger or that sadness or whatever, and it feels out of your control, which then creates a sense of anxiety as well, because you don't like that feeling of being out of control. And it's one of the most common experiences in the perimenopause is that sense of your emotions just aren't your own. You don't feel like your normal self, because you're just blowing up at your partner, or you're crying at the drop of a hat, or whatever it is. And it's one of the most common constellation of symptoms that women find around this time.
Yeah, for sure. So how often do we hear stories around, oh, I just lose my temper at the drop of a hat, or I know that this is a little thing, but I just snapped and I don't like myself for losing control, but it's just overwhelming. And one day I'm terrible and the next day I'm fine. And all this, it's a very common experience. The other thing that I think is quite fascinating is this sense of doom, this fear of what's happening in the world around us, and this increased sensitivity to events, world events and stuff, inability to watch TV shows or movies that are very emotionally provocative, or these are kind of new experiences that women share, and they're quite common, aren't they?
I know in my experience, I found that ads on the television, I would just cry, like and I would cry and cry and cry, and then and then I would cry because I was crying.
Yeah.
Like it was just out of my control. I just couldn't do it. I always feel a bit, silly and stupid afterwards, but I also felt good for having a good cry.
Yeah.
But it just felt completely out of my control, and I just didn't like it at all.
No, I think some of the NRMA ads really get me. I forgot to, I was going to ask you more about your perimenopause and menopause experience. So maybe we can just take a little time out to do that and we'll come back to the hormonal changes of perimenopause and mental health. So sorry, I forgot to ask you that, but could you share a little bit about your own personal experience in
I think
addition to commercials?
my experience was pretty profound. Almost overnight, my hair went from slightly wavy to ringlety, curly, and my hairdresser couldn't believe it. Like he was just like, I don't know how to cut your hair. It's like someone else's head, like it's weird. And I've had to adapt because I've never had hair this curly, and it's exactly like my mother's hair. It was crazy. But the other thing that happened for me was I got seriously depressed. I got very unwell, hospital unwell, and it was I had had issues with depression in the past, but this was such a profound experience of being unwell that my whole life changed. And I live in Tasmania, and there were issues with the hospitals down here, and I had to go to Melbourne to go to hospital. I had a teenage daughter who didn't cope with that. So it was a really profound impact. And on top of the medication, I was started on some estrogen, and it was almost like a light was switched on. And I could see that this was not, I wasn't condemned to feeling this depressed for the rest of my life. And gradually I could get better. And I guess I was already very interested in women's health and was doing a lot of it in general practice, but it was one of those life-changing experiences where, um, as I said, that light switched on after a couple of weeks of being on some estrogen, and I started to get better after that time.
Wow, and how do you find, how are you now? Like what happened since then?
Well, I feel like it was a real opportunity because I have greatly changed my lifestyle so that I am now living the things the lifestyle issues that I talk to my patients about. I'm actually doing it myself. So I'm paying a lot of attention to my own sleep. I'm exercising regularly every single day. I'm exercising. I'm walking, but I'm also doing strength exercise because I know that strength and resistance improve my mental health, but also my bone strength and my muscle strength and my brain strength. I'm eating much better. I'm not drinking any alcohol, blah, 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 blah. I'm taking all my own advice and actually doing it for the first time in my life and having these amazing impacts from that. And I feel like a new person. It's great. Yeah.
Fantastic. So you're speaking from a really intense personal experience when you talk on this subject.
Yeah. Yeah.
So what happens why is it more a mental health is more of an issue, or disturbances of mental health more of an issue in perimenopause than menopause? What do we know about that?
I think it's largely due to the fluctuations in the estrogen levels, in the blood estrogen levels. It's the same for women who experience the premenstrual dysphoria, it's that shift in the hormone levels and that sort of, I'm going to say the word instability, which just creates that mood change. And it's not until like the postmenopausal women have their baseline, and the perimenopausal women have this sort of fluctuating estrogen levels, which the brain doesn't cope with quite as well. And it causes those mood and anxiety issues, but also those sort of irritability and emotional dysregulation experiences as well.
Mm. So after the menopause, it seems to be that mental health improves and stabilizes. And I would maybe I would also say that if mental health issues arise after the menopause for the first time, I would be looking at other causes, not primarily hormonal causes, if that was the situation, because it seems to be so characteristic of the turbulence of perimenopause. There are some people, I think you mentioned yourself also, there are some people who are at increased risk of having worse mental health during perimenopause. Do you want to mention a few of those people? I mean, it can happen to everyone, anyone, but there are some people at increased risk.
I guess if you've had a history of mental illness prior to the perimenopause, you are at higher risk of developing issues at the time of perimenopause. But also if there's ongoing trauma or stress that's sort of unrelenting, there's not the same capacity in the system to deal with that unrelenting stress. So those people with stress, particularly high stress levels and trauma, are at increased risk of developing mental illness around the time of the perimenopause.
Yeah. And there's also that group, I think, that have a hormonally driven mental health problem. So women who have previously had postnatal depression or depression or anxiety on some contraceptive pills or bad premenstrual mood disorders, PMDD, they are also possibly at increased risk because they have a hormonal relationship with their mood demonstrated in the past. But again, it's such a common experience that it affects well more than just those women. So given that it's common around perimenopause, how do we approach these symptoms in perimenopause?
That's a really good question, and I think we have to do it on an individual basis, because not everything suits everybody. So I might have what works for me probably doesn't work for anybody else. So it's about finding your own path in this journey about what is going to work for you. And you have to be prepared to try a number of things until you get what you need. Okay, so I think that there are all the basic things like sleep. Sleep for me is as important as breathing. And if I don't get good sleep, then I need to address that very quickly or my mood goes down. So, and sleep issues are so profoundly common in the perimenopause that I think that it profoundly impacts on our mood and stress levels. So some people have the trouble getting off to sleep. Other people have waking with the sweats. Other people just wake and can't get back to sleep and their brain is going at 100 miles an hour. And other people just wake up at 5 o'clock in the morning and that's it, they can't get back to sleep. So everybody has a different area of vulnerability, I guess, and there are different measures that you can take for each of those. There's things that we need to avoid, like reducing or cutting out alcohol, because the alcohol has a huge impact on sweating and hot flushes, but also has an impact on sleep. Avoiding smoking, doing regular exercise. So whatever exercise floats your boat, go for it. That's great. But I would recommend both aerobic and resistance exercise, so that you're addressing your strength, your fitness, but also your bone strength and your brain. Because I just read a study that shows that resistance training actually helps prevent or reduce your risk of Alzheimer's. So regardless of how much you do, just doing it is actually really beneficial. So all the lifestyle factors really need addressing for each individual, and working through what's working, what's not working, maybe providing some examples. There are lots of apps out there for meditation and sleep, and apps for training, and so there's so much available. And I love to learn from the people that I talk to about what works for them, because that might be able to work for me or work for, other people that I come across. Yeah.
Yeah, I think we've seemed to have got to midlife also without a lot of real, sometimes without very effective tools in our toolkit for managing mental health. And one of them that you mentioned just then is sort of meditation, and it doesn't have to be an extreme thing. It can just be a breath practice, which calms the nervous system and lets you to center and so forth. So often, just if you're doing nothing of these particular lifestyle factors, if you're doing no exercise, if you're drinking way too much, reducing or moving one step towards better is often quite effective. And it's not an all or nothing thing. Something is better than nothing. And that's why it's not about what is the best exercise for this symptom and this outcome. Well, one, we don't really know often what the best exercise is. It's hard to study, but doing something is better than nothing. And moving in the direction towards ideal, which of course, I have a background in sport and exercise medicine, so that floats my boat. But the ideal baseline exercise is 150 minutes of moderate intense physical activity a week. So that looks like 30 minutes of brisk walking 5 days a week, and 2 sessions of strength training, which could be in a little bit of a circuit and be included in part of that aerobic. And then we know that's a good level because research tells us at that point we reduce the risk of many chronic diseases, heart disease, dementia, cancer, all sorts of things at that level. We halve it at that level, and we get further benefits if we increase that to 300, and beyond the 300 minutes, we don't get necessarily the same degree of benefit. So that's where that number comes from. It's the risk reduction of chronic disease. But it's not just the chronic disease that we stick to physical activity at the moment, but also alcohol and nutrition, general nutrition and sleep. It's actually, you feel better when you're doing it. Your mood lifts and you sleep better and you feel more energetic if you're able to do it. And often when it comes to exercise, it's often hard to initiate. You've got to get changed perhaps or whatever. So looking at your own individual barriers to doing some exercise, we can sort of navigate them, because sometimes you don't have to get changed. You just have to put on a different pair of shoes and go for a walk. But it's one of those things that you have to do it knowing that you're going to feel better at the end, rather than because you feel like doing it at the beginning.
That's
So
right.
not everything we do, we feel like doing, but we know we'll be better at the end. So we can still hold ourselves to account in that way, even if we don't feel like it. I don't like exercise. I don't do this. I don't feel like it. Well, you probably feel better if you do a little bit of it, and then we can work backwards.
Mm.
So where do hormone treatments come in, do you see, with respect to mental health and perimenopause?
I mean, resoundingly, my experience is that adding in some hormone therapy at this time of the perimenopause can profoundly have this impact on re recalibrating, reorganizing, resettling those symptoms that are causing distress. So some people just find their equanimity again. So that irritability, that feeling of being out of control just tends to settle quite well with some hormone therapy. And once again, on an individualized level, but it it just evens things out so that those huge shifts in those hormone levels just get leveled out, so you don't have that same vulnerability to those extremes, and you feel more yourself again, and which in itself is a positive feedback so that you can do the things that you need to do to help you feel better. So,
Yeah,
yeah.
yeah. Um, and there's a lot of talk in social media in particular around women being prescribed antidepressants in perimenopause when they should be prescribed estrogen specifically. But it's not that simple, is it? In some cases, that's true. And we certainly know that if someone responds to menopause hormone therapy, they respond within usually a couple of weeks,
Mm,
quite quick. But what's your take on the role of antidepressants? Because I don't personally believe that all women with mental health concerns during perimenopause will be treated with hormone therapies, and particularly those with mental illness.
mm, mm. Um, so, I mean, definitely, I mean, the two can be used in conjunction, so you don't have to do one or the other. But what I tend to do is if I am using an antidepressant in someone, I separate the time. So if I'm doing menopause hormonal therapy and an antidepressant, I won't do both at the same time. I will do one first, and I usually do the MHT, the hormone therapy first, and see what kind of impact that can have, because I know that it can have a profound impact on not just someone's mental health, but also the other symptoms that you experience during that period of time. And if the mental health symptoms or the mental illness symptoms are still pervasive and disabling, then I would start the antidepressant and monitor that quite closely. So as I said, doing the two at the same time, you don't know what's doing what. And I always start at a fairly low dose of the antidepressant, because I find that women in the perimenopause are more sensitive to the side effects of these medications. If you're not using MHT, and someone's having, severe vasomotor symptoms like the hot flushes and the sweating, there are specific antidepressants that we can use to address those side effects. So, and they also do have an antidepressant anti-anxiety effect, which can be quite profound as well.
Yeah, because of course some women are unable or choose not to use hormone therapy, and so there are still other options for those women, in addition to those lifestyle measures. Yeah, so I guess the take home around the antidepressants is not that, or it's not either or, and sometimes both are required. Antidepressants don't suddenly become the devil because you're in perimenopause.
No.
So I would just wanted to mention around women, the symptoms that women sometimes experience around late reproductive stage before their period is irregular. So when a woman's period is still regular, but that might be 42, might be 43, They might be getting some symptoms of sleep disturbance, some brain fog, some irritability. That's quite common and recognised, and it is a hormonal change. But the changes that happen at that time are not the same changes that happen in, when your period is starting to skip or your period is stopped. And so you often don't have low hormones at that time. So it's a different hormonal trigger. And it's a little bit more like the hormonal trigger that someone with PMDD might be experiencing, or severe PMS. I know the PMDD has its own definition, but if we think of that PMS cluster of mood disorders and we think of that like on steroids, literally, and then it's prolonged, this is what we see in that stage before your period becomes regular. And when we talk about hormone therapies, women, a bit like the antidepressant chat, the contraceptive pill is not included in the bucket of hormonal therapies, but that's exactly what the contraceptive pill is. It's a hormonal therapy that has significant benefits when you're still getting a regular period, because it overrides the ovarian cycle and blocks out the communication between brain and ovary, which is the problem in that stage. So at that stage, you're not needing estrogen replacement. You have heaps of it. It's the disorder between the brain and the ovary. And so that the pill is the only thing that will do that. So that it's one of the things that will do that, because menopause hormone therapy won't override that. So the pill has a clear place in the treatment of PMDD, severe PMS, and also in women with mood disorders when their period is still regular. And I think that women feel a little bit that they need to push back on the use of the pill as a hormone therapy. But as doctors, we think of the pill as just another version of hormone therapy.
Absolutely, absolutely. And you can choose, I mean, there are so many pills around. You can choose a pill that has less mood impacts, and if anything, positive mood impacts than not. So you would be specifically choosing a number of pills that have less. I mean, a lot of women say that, oh, I went on the pill and I got really depressed. Well, maybe that wasn't the right pill, but we have a number of pills to choose from, a number of different types of pill that we can use that have positive impacts that aren't associated with negative mood impacts.
Yeah, for sure. And sometimes we need to trial amongst them.
That's right.
So yeah, so we leave that on the table when it comes to hormone therapies and mental health. Are there any surveys that women can do to check in with their own mental health and get an idea of that? I often, I think we mentioned before, I use the DAS-21. So tell us a little bit about what that is and what that might help with.
So the DAS-21 is a little questionnaire. It's a really compact little questionnaire, and you just rate yourself according to a number of different areas, and you get a score at the end, which can give you an idea of whether this is, or whether the symptoms that you're experiencing are mild, moderate, or severe. And for example, if you're consistently scoring in the moderate to severe, then I would say you need to go and see someone. You need to see your GP, or you need to talk to your psychologist, or you need to get some assistance. A lot of people find that their scores do vary over time, but it would be something, if you're not sure about how bad your symptoms are and you don't know whether to say something, or you feel like your symptoms are quite bad and you just want to check in about that, then doing something like the DAS-21 can be really, really useful. And you can just Google it and get access to it that way.
Yeah, and some of them have the scoring normative value, so that some of them just have the survey, but other PDS will include what the different scores actually mean, how to interpret it. So look for one of those, and of course, don't manage yourself if you're very. Reach out to your GP in the first instance if you don't have any other care connected team, psychiatrist, psychologist, or whatever around your mental health. So I think we covered the subject of what happens if you don't get better. I think we covered the fact. Did you want to just touch briefly on that as a subject? What happens if you're on hormone therapy, you've made some lifestyle changes, and you're just no better.
Well, you need to check in again with your GP or your MHT prescriber, and and then, you know, the question is are your symptoms consistent with a mental illness, and do you need further treatment for that? And does that treatment involve medication, like an antidepressant? Or does it need some therapy through a psychologist? Or, you know, what is it that you need to help you feel better? And if you were to start an antidepressant, for example, and if I was to start a patient on an antidepressant, I would never expect them to be on it for the rest of their lives. I would say, let's do this for 12 months or 6 months, and then let's reevaluate how things are going at that time. And then, do you need to be on it for longer, or can you come off it? You know, what's working for you at the moment. So if I was to advise someone that it would be a good idea to start on an antidepressant, I'm never condemning them to a lifetime of medication. It's just, let's just see how things go over time, and we can adjust things as necessary.
Perfect. Now, we said we discussed beforehand that we're not going to flesh out this subject terribly much. We're not going to spend much time on it, but I'm going to throw it out there because the other cognitive symptoms, just to touch on for completeness, the other cognitive symptoms that women often describe around the perimenopause, especially, is brain fog. It's very common, it's poorly defined, but there are some recognized reduced functioning in terms of verbal memory and recall that women experience around the perimenopause that do improve after the menopause, but not necessarily go back to baseline and are not predictors of dementia. So this is a true phenomenon, which I often find a little interesting, that, you know, my husband can forget where he leaves his keys and he's fine, but if I forget where I leave the keys, it's my hormones. It's like we just blame our hormones for everything. And a lot of what we experience is just normal, being busy, being in midlife, being human, whatever. But are you able to say just a little bit about ADHD? Because we're not going to flesh this out into a large discussion. I don't see it as controversial, but what we are seeing is a lot of women using the VIV service have been recently diagnosed or whatever as ADHD. So I think there's a little bit of confusion as to whether perimenopause unmasks causes HDAD, whether it's separate, whether it's part of perimenopause. Just given your experience, what do you make of it without spending more than 1 or 2 minutes on this subject, because it's beyond the scope of our mental health focus, but it is a mental health concern or a cognitive concern that women have.
Yes, and it's increasingly, as you say, it's increasingly coming up amongst the VIV members that there's this co-diagnosis. And I'm a bit cautious about pathologizing something that's quite normal. So I think, as you say, we all talk about the brain fog, and to some extent, as you say, like a busy lifestyle, a bit preoccupied, it can be really hard to keep track of absolutely everything that's going on in our lives. And if you think about where women are at around the perimenopause, they've often got teenage children or parents that are aging. So it's a multi-generational form, like stress coming up. And I think that it can be hard for us, you know, we're often working as well, or we've got businesses, we've got responsibilities. It can be very hard to maintain everything at the same time. And I think that the distress associated with the brain fog, or the inability or the difficulty keeping track of everything, um, is quite real, but it's not necessarily a pathological diagnosis. And but I find that there's a section of women who have chronic disorganization and inability to maintain time frames, and the diagnosis or those symptoms become completely highlighted at this time because of those associated stresses that we all have, but they've got this vulnerability, and it, as I say, it becomes completely highlighted at this time. And for some women, going on treatment for the ADHD is life-changing. For some women, it's not. But for some women, it's like, why haven't I been doing this all my life? But that's a smaller group compared to the majority of women that I'm seeing who are just struggling with life because it's a really tough time of life for
Yeah,
everybody. Yeah.
yeah, for sure. So if we wind up, maybe you could just share your, closing comments or final message around the concept of mental health.
Yeah, so mental health is a good thing. So when you're mentally healthy, you're doing well, but that doesn't mean you don't experience a range of emotions. And stress, anxiety, moodiness is completely normal at any time of life, but it is highlighted around the perimenopause and the menopause. And I think we need to be kind to ourselves and not be too hard on ourselves about what we are experiencing and the way that we're reacting to the stimulation that's happening around us. So, but if your symptoms are severe and persistent, then you really need to seek help at this time.
Yeah, beautiful. Well, thanks very much for sharing your thoughts and your experience, and especially your personal experience. And everyone have a great day. Thank you, Juliet.
Thank you. Okay.